It's an honor to be here today to be speaking to you about a topic that's very important to me, and I think it's a timely topic as well, given we have an aging population and given the demographics that are developing. Stroke is going to be an aspect that's going to be affecting all of our lives at some point, a loved one, family member, friends. And so I'm going to be speaking about the treatment of stroke patients with telemedicine, and we'll talk about what that entails. All right, so where does this term stroke come from and the definition? What are the causes? So if any of you recognize this gentleman, this is Hippocrates. So 2,400 years ago, a term called apoplexy was actually given to people who would develop sudden onset of paralysis and a change in well-being. And at that time, actually, they took it from the Greek for being struck down by violence, right? So in the mid-1600s, the mechanisms of stroke were actually better defined, one being a blockage of a major blood vessel versus hemorrhaging into the brain. And it was renamed stroke in the early 20th century. And now many times we actually refer to stroke as a brain attack or a CVA. And you might hear actually a code stroke if you're in the hospital to actually show how important treating this condition is in a very timely manner. As you know, people with heart attacks, MIs, myocardial infarction, they have pain, and it's very classic in terms of how it presents. But with stroke, it's so variable, and there's no pain associated with this condition. So it's really important to stress the timeliness of treatment for this condition. So going into the incidence and the risk factors for stroke, it is the third leading cause of death in Americans, and it is a leading cause of adult disability as well. And each year, up to 750,000 Americans are affected by stroke. Every 45 seconds, somebody in the United States actually suffers a stroke. And every 3 minutes, actually somebody dies from a stroke. And the good news is that up to 80% of them may be preventable, right? There are non-preventable risk factors. So that includes age, genetics, and the fact that somebody had a previous stroke probably makes them more likely to have another one. But there are many modifiable risk factors. These are things that you can actually do something about, either with lifestyle changes or medications or other interventions as well. So there are many people who have high blood pressure, diabetes, high cholesterol, right? These are treatable. Smoking, obviously, there are many programs out there to help people stop tobacco use. Carotid artery disease, when there are blockages in the major arteries that go into the brain, there's a surgery that can actually reestablish blood flow. Heart arrhythmias, that can cause clots in the heart that can travel up into the brain and cause a stroke. We have very good blood thinners, and we have procedures that can actually reestablish a normal rhythm of the heart. Obesity is a major cause and a risk factor for stroke as well. And then there's also alcohol and drug abuse. Stroke symptoms. I'm sure that we're all acquainted with some of the more major and obvious stroke symptoms. Drooping in the face, weakness in the arm or leg, trouble speaking, trouble expressing somebody's speech, and trouble with walking, vision loss, and even body numbness, right? Sometimes, though, the symptoms may be very vague. It might be a balance problem. With bleeding in the brain, it could be the worst headache of your life, right? So in terms of when symptoms start, it's really important to get on the phone and call 911 because, as I'll go into later on, you'll see that the treatment of stroke is time critical. The faster that you can recognize stroke symptoms, get them to an emergency room, the faster that you can actually deliver a potential disease-modifying treatment. There are many causes of stroke, but the main ones are the two categories. One is in which a major blood vessel to the brain or an area of the brain is occluded, either by a blood vessel slowly being blocked off over time with plaques developing from atherosclerosis. And then there's another type of blockage of an artery called an embolism, where a blood clot from the legs or from the heart or somewhere else in the body travel up the circulatory system into the blood vessels of the brain, causing a stroke. On the other hand, the rest of stroke, about 20%, is typically caused by bleeding into the brain. And this could be due to severely high blood pressure, or it could be an aneurysm that bursts in the brain. These are quite lethal as well. So again, both of these conditions, there are treatments that we can give in a timely manner that might alter actually the course of the disease and improve recovery and disability. Looking at the cellular mechanisms of stroke, once a major blood vessel to the brain is occluded, actually what happens is that the oxygen and glucose that is delivered to those cells is lacking, and this results in a disruption of the energy production of brain cells, of neurons. And after a while, instead of just being shocked and the cells not functioning, the cells end up dying permanently or permanently damaged. And for every minute that actually passes, 2 million neurons are permanently damaged. So again, time is a factor. Time is brain. And the larger a stroke area is affected in the brain, the more likely it is that there will be a worse clinical outcome and worse deficits over time. And the brain has a map. Different areas do different things. There are areas that control speech, vision, movement, thinking, memory. And depending on where the strokes are, you can see that you can get different types of symptoms. Now, just going into some terminology. Once a stroke does occur, once there is a major blood vessel blockage, the clock is ticking, right? If you look here, there's a diagram where you see a red area and a green area. There's this term, the ischemic core, right? Ischemic means a blockage of a blood vessel causing brain damage. The ischemic core is actually the initial area where the neurons are permanently lost. There is an area served by the same blood vessels that is still salvageable. These cells are shocked, they're not functioning correctly, they are causing neurological symptoms, but you can still save them. If you can re-establish blood flow within a timely manner, you can actually intervene at this point. But as time goes on, as that blood vessel continues to be blocked and those nerve cells are starved of oxygen and glucose, over time that red area, the ischemic core, will get larger and larger, and the salvageable area gets smaller and smaller. And there are some patients who don't realize that they're having a stroke, or don't get to the hospital in time, or don't have treatment available to them, and they end up having a complete stroke, where the whole territory of the blood vessel is affected, and that results in a worse disability and trouble functioning. I'm glad to say that there are some wonderful, amazing interventions that we can now offer stroke patients. When I started my residency in neurology, the first few years, it was basically give aspirin, give fluids, I'll come see the patient in the morning. By the end of my residency, I was driving to the hospital and giving this medication to patients to actually reestablish blood flow in the brain. It is called TPA, Tissue Plasminogen Activator. It is a clot-busting medication. It is very powerful, and you can give it in select patients who have had stroke symptoms for less than 3 hours by FDA standards, right? In some cases, we can even give it up to 4.5 hours, but typically 3 hours is the time that we measure from when the stroke started, okay? This medication, it's really important to know not just when the stroke started, but whether they're taking any blood thinners, whether they've had any recent surgeries, because while the medication can improve outcomes in more than a third of patients, there's actually a 3% risk that they can bleed into the brain or other areas of the body, and they can get clinically worse. So making an accurate diagnosis is really important. Aside from that, for patients who don't improve enough from this medication or the clot is too big, we have something called thrombectomy, which is a device at the end of a catheter that we can snake up through the blood vessels of the body into the blood vessels of the brain, trap a clot, and actually pull it out. This is a procedure that is highly technical, done by interventional radiologists. You have up to about 8 hours to provide this procedure. Both of these procedures may be done together, and you can actually improve outcomes, reduce disability. There are some patients who actually walk out of the hospital without any deficits if they're given these treatments in a timely manner. There are many challenges, though, delivering this care. As I said, you have 3 hours for delivering TPA, 8 hours for giving a thrombectomy procedure, right? Some patients might not realize that they're having a stroke. They might brush off the symptoms. They might not live close to a primary stroke center where these services are available, or doctors might not be available who can provide this type of treatment. So, considering all these challenges, how can we provide these services using possibly technology and robotics, computers, Wi-Fi, video conferencing in this age? How can we fill in the gap? That is the role of telemedicine, okay? This is a physician operator who uses a computer or a tablet device with wireless control of a robot remotely to examine a patient with staff assistance in an emergency room or in a hospital setting. Combined with this remote access to view imaging, review labs, working with an emergency room physician and nurses, we can help with making decisions on whether patients are appropriate to get these treatments and then even get them transferred to another hospital for a higher level of care. So now you can see that telemedicine can actually bridge these treatment gaps in the fields of neurology, radiology, and even psychiatry in some areas that this is being delivered. A stroke network is a hub and spoke model where the hub serves as providing the services, Telestroke services, and actually taking patients who need a higher level of care. And spoke centers are the centers that actually receive the service for telemedicine. And neurologists are remotely beaming in, examining patients, guiding delivery of TPA. And the services result overall in a reduction in what's called door-to-needle time. That's the time that they come into the hospital to the time that they get the TPA delivered into their vein intravenously. There are many components to a successful telestroke network. That includes a telestroke neurology panel. Obviously, it's not just one neurologist who's delivering it. On our panel, we have 5 doctors, stroke coordinators and nurses who provide education and coordinate care between the hub and the spoke hospitals, obviously IT services, and working very closely with our emergency room physicians and nurses. For a comprehensive stroke care team as well, if patients do get transferred to one of these centers, you need critical care transport nurses in an ambulance. At our center, we actually have a rig with ICU-trained nurses who travel with the patient as the medication is running so that they can get to our hospital in a very timely manner. Interventional neuroradiologists to do those thrombectomy procedures, neurosurgeons, and ICU-trained nurses as well. So just going over a summary, stroke is a leading cause of preventable disability. There are treatments available for acute stroke. It is achievable with timely medical and interventional technologies. Once you appropriately recognize a stroke, it can be managed, and with the delivery of these medications and devices, you can end up getting better outcome for patients and reduce disability over the long term. Telestroke physicians may actually deliver neurological care remotely using these technologies to patients in outside facilities, either next door or in another city entirely. Future stroke care actually may change over time. There are now places in the United States where there are running trials using ambulances that have a remote CT scanner in addition to a remote technology connected to a neurologist, to scan patients to determine if they're having a stroke and to deliver TPA in the ambulance on the way to the hospital, right? So this is probably the future of stroke treatment. So ultimately, what I want you to go away with is that time is brain, and we do have treatments available to treat these disabling conditions, which may be preventable in many cases. Thank you.